I would like you to stand up if you know anyone personally who has been harmed or had a near-miss error in a hospital. Do you know anyone personally? And I'm standing up, but I would be one also. Please sit down. Think about that. I mean, that's personal. It happens. It's happened in my family. What you are doing is so important. This is not numbers. Ralph Rosen and I were just talking about this earlier. These are people we love. We talk about things like the ODE ratio or our sepsis rate, but those hide the fact. The fact is, these are people that we love in our care, and we're responsible for taking care of them. One of the things that just amazes me, and has amazed me through most of my career, is our acceptance. Hospital administrators, physicians, all of us in this room, our acceptance of error rates. Think about that, y'all. We accept error rates. We accept O/E ratios of 1.2. A nuclear industry would not accept the fact that their error rates or their was 20% higher than what it should be. Or an airline would not accept that fact, but we accept that. We have to change that. Our only acceptable level is 0. And if we, if airlines can do what they do and nuclear power can do what they do, we can do better. There's really no excuse. There's no excuse for a central line infection. There really isn't. We can do this. So now, to make this a reality, that we have 0 acceptance for errors, the first step of today's journey to improve quality, I would like to introduce Keith Granger. No one that I know on the administrative side personifies or takes it to heart, quality to heart, as much as Keith. He is probably the best quality administrator that I know. Keith is the regional president and market CEO for Community Health Systems, and he's our first speaker for today and our moderator. His presentation is going to be the impact of the quality improvement work on a hospital's patients and its bottom line. Keith has led the association's quality efforts since 2004. He meets with quality leaders and infection preventionists on a monthly basis to help share best practices. He speaks nationally on the subject of quality and has led 2 hospitals in Alabama to top tier on quality measurement. And he's the former chairman of ALAHA, gold medal winner, and a current board member of ALAHA and current president of the Birmingham Regional Council. Please join me in welcoming Keith.
Thank you, Will. It is certainly a pleasure to be back with all of you again. As I was standing there just a moment ago thinking, 12 years ago we started these quality forums, and we've had 2 a year ever since. Many of you I know have been a part of that process throughout those 12 years, but I am personally very proud of the work that we've done in Alabama. I think it is definitely a commitment that has been shown by the senior leadership in your institutions and by many of you in basically taking this very important topic and elevating it as a part of your operation to improve care across our state. I was also reminded as Will was speaking and asking you to stand. And I would tell you as we talk about various issues and I give this update today, one of the things that continues to concern me, and you will actually hear me in one of the closing slides, I'll be pointing out our need to look at mortality in our facilities. And as Will was describing that, sepsis particularly comes to mind. I think for many of our years over the last 12, we probably have spent a lot of time talking about infections, and we've talked about CODIs and CLABSIs and surgical site infections, and you name it. I think sepsis has to be, and I know that we've elevated that topic the last several years, but if you really want to take a serious look at it, go back to your institution and look at the number of deaths you have every year, and then specifically look at the leading cause of death in your institution. And I suspect one of the top 2 death factors is going to be sepsis. And if you think about that, essentially these are people that lives can be saved by early intervention. So to get you started in thinking this morning, I want to make it just like Will did. I want to make it very personal. I actually asked our managers at a recent meeting at Grandview, this was probably a month and a half, 2 months ago, I asked all of them as they left a meeting room one day to write down the name of a family member that they would be willing to let get sepsis and die in our institution. Trying to drill down the fact that this is personal, as we heard earlier. But that essentially is what we're doing if we're covering our eyes and acting like this doesn't exist. So I'll talk a little bit more about that, but to open our thoughts this morning, I did want to make sure that you understand that this is a personal statement. And I really think we have to think about it. What are we doing to save those lives instead of letting those people go through our routines, and sometimes our routines not living up to the standard we would want. So with that as an overarching statement, I want to share with you today in kind of a global high level some information in this presentation, and I'll be going fairly quickly. I'll be trying to cover a lot of different points in there. I'm not going to get into a lot of detail, but what I really want to do is just stimulate your thinking about the work that we've been doing and about the work that is in front of us. Because I realize that if you are energized and inspired when you leave here today about the work we have to do in our institutions, that there's enough horsepower in this room, there's enough energy in this room that we can continue to make a huge difference in the care of the people that entrust their lives to us in our institutions. So that is my ultimate goal in terms of trying to get this particular presentation to you. I hope that some of the information in there will be something that you look at later. I'm not going to try to go over every element of every slide, but there's a lot of information that we tried to put together in a concise way that hopefully would be helpful for you when you get back to the institution. As you can tell from the slide's topic here, the presentation, quality, the true sustainable strategy to ensure viability. What I'm really trying to say is the work you do is one of the most important elements as to whether your institution is going to survive. Why should you care about that? It may be the only institution in your community providing those services, or it may be that you are the entry point for those citizens in your community getting to the next level of care. So your survival, your vitality in the community is critical for us to have an effective program in our state. And I think there's an awful lot of people that thinks the work that they do in an organization is important. But I would assert to you that there is nothing more important than taking on quality as an initiative in your organization. I think it is important that we link the financial viability of our institutions to that. And I believe it is important that the clinical processes of care, if you are not directly linked to your CNO and directly linked to your nursing areas, and quality is embedded in a department, and most people think that the quality work of that hospital occurs in that department, you are missing the boat. This is about delivery of care at the bedside. This is about changing and improving the processes at all levels of our organization. And it is about ultimately the reputation and the brand that your organization has. If you have bad quality, you have bad care. If you have bad care, people will learn that and they won't come back. If they don't come back, you will ultimately fail. It's really a pretty simple business process. So the more that we can do to link quality to the brand, the reputation, the bedside care, and ultimately the financial viability of your institution, then we have best served our community by doing so. So again, that is where we start. Not sure where that is, but we'll move on past it. Okay, here we go. Federal quality measurement and transparency. There have been a number of elements that have occurred over the years. As we have seen them unroll, we started, as y'all know, our quality movement here in Alabama about 2005, about the time we anticipated what the federal government was going to be doing. It has continued to elevate its activities. A number of these programs were introduced after we started, and a number of them were anticipated and actually came out of the work that initially occurred on the process of care measures. As we have continued to see them grow, you can see that there are a number of elements that you've had to keep up with in your departments, and you have become more and more complex and comprehensive in those activities. and again, all the way up to and including the meaningful use. But when we look at these programs, one of the things that we're seeing is that we're seeing about 9% of your payments are now at risk. Okay, think about that. Some of your CFOs would be very impressed to know this much money is at risk, and maybe they do know that. But the reality is, how much of it are you giving back every year because of the manner in which we perform? If you look on the Hospital Compare website, you would find generally the data is being reported in these 5 elements. I'm going to spend most of the time today talking about the first 3 elements. I'm not going to spend as much talking about the CJR and the EPM, because those are newer elements and they're not universally used by all of our facilities. So today I'm going to try to stay at a global level of something that applies to almost everybody in the room, and certainly you can look more detail if you want to look at one of the other programs. One of the quickest and most important things to let you know right away is last week, CMS decided it was not going to update the star rating. Some of you may be applauding that. You may be proud of that. You may be glad because you may have had a deteriorating star rating. Others in the room I know were looking forward to an update because their numbers had improved. They worked hard to try to get those improvements. What is the future of the star ratings? I don't think anyone knows. I can tell you that the Hospital Association and many others have been challenging and trying to point out to CMS a lot of the flaws relative to the way the star rating system has evolved. On the other hand, as long as it's out there, we better learn to play within the rules that are there so that we can continue to elevate our performance at every opportunity. But right now, there is no defined date for the next release of the star rating, but it will definitely not occur in October as it had been originally planned. So I want to pose this question to you because it's important to think about it. We keep using the term pay for performance. We oftentimes, I think, thought that it was extra pay for our performance. But if you really looked at the elements and you think about it in terms of how it's actually being applied in many of these cases, it's not extra pay. It is actually trying to hold on to what you otherwise were due, and in many cases, it's turning around to be a penalty if you look at several of these programs. And I'll talk about a few of those in just a minute. But just as you work through your processes in the organization, realize there are real dollars being taken away from your organization unless you are performing at the highest possible level and are actually getting the benefits and bonus payments that might be available through the value-based purchasing component. Otherwise, you're likely going to have less money than you otherwise as an institution might have been entitled to. Now, a good example today I thought about doing and chose not to. I was going to ask you to all put like $100 on the table, but I realize you're probably like me and you might not have $100 with you. But imagine sitting at the table that you're sitting at today, and if I had asked you to put $100 on the table when you walked in the room and just leave it there all day. And at the end of the day, we're going to let the person who has the longest arms or perhaps the highest scores reach over there and get some extra money in addition to their 100. And others of you who have short arms or poor performance, I'm sorry, I'm just using that analogy. So if you have short arms, not trying to offend you, but just trying to distinguish something that says the long arm people get more because they can reach further and the short arm get less because they couldn't reach as far. How would you feel about your money walking out of the room with another member of this table today? Essentially, that's what's happening if your hospital's not performing. You're putting your money on the table and your competitors and others are getting that money. Now, I don't know about you, but I like getting other people's money, but I don't like giving up money, okay? Because it's so hard to get in the first place. I sure don't want to give away the fact that it's probably money that's paying 2 coworkers jobs, or it may be a piece of equipment that I wanted to get for the next year. Just think about that as we go through and as you accept the fact that you are not achieving at the very highest level. Are you really accepting that it's okay to give away your institution's money to somebody else? The other question I want to pose early on and have you think about as we go through this. I think in 2005, we talked a lot about the importance of creating a team. And I think some institutions bought into that, and some institutions went out and embraced that. And I think those are the organizations that we're seeing some of the higher scores come from. I think in other institutions, people remained in a silo. They found it difficult to get all the collaboration and coordination in their institutions. In some institutions, I've had the pleasure of being invited to come and see and listen, and other organizations that I've spoken in front of. It's amazing to me that case management, quality, and nursing don't talk to each other. They exist in their own unique areas. There's not a correlation between length of stay and infection rates. There's not a correlation about medication education and case management and discharge planning. How in the world can you have a quality organization if you have barriers and silos for those activities? And that's just a small example of the activities I'm describing. If you don't believe that quality is changing the delivery of nursing care at bedside, then you're missing the boat. So if those relationships don't exist in your organization to have those individuals all working closely together, there is no way that you will have good processes and good outcomes. And clearly that's going to show up in the numbers. And again, we'll dig into some of those specifics in a few minutes. So again, I'm not going to read down the entire list. You can read it, and the list is far more encompassing than what I have listed here. So this is not the end of the list. This is just to stimulate the fact that these are all important and many others should be there. Again, I think quality really has an impact in three critical areas in our organizations. That is, it is all about our reputation. If the public does not believe you represent quality, if the public does not believe that patient experience at bedside is positive in their institution, why in the world would they go to your institution? If you are not going to have a good patient experience, if you're not going to get the clinical outcomes they're expecting, why would I take my loved one and entrust them to your care? So if you want to spend a lot of money on marketing your hospitals and your communities, that's great. I would suggest to you, though, the best marketing that any hospital can continue to have is the reputation that's developed at bedside by the caregivers who provide the care, and the empathy and the compassion and kindness they show to the patients, and the clinical outcomes that come from the quality programs that you put in place. To me, that's the real marketing, and that's what will create the sustainability of your organization. So that's how we lead to the financial security at the bottom. Anybody that can run a good organization without volume, my hat goes off to them. If you don't have sufficient volume coming into your entry points, if people don't have enough confidence to continue to use your institution, you will not have viability, and you will be one of those facilities that close. And I will tell you today, I believe that there will be another 5 to 10 Alabama hospital closures in the next 5 years. I think we have that many facilities or more on the edge of financial collapse, because we've got to find ways to keep the reimbursement rates up, and we've got to find volume and entry coming into our facilities. And again, I think the way you build that is around quality. So let's talk about value-based purchasing in just a minute. I mentioned that we were going to be covering several areas here. We started out with a bang. I think a lot of that is attributable to the fact that we had many of you working very closely on these topics and these initiatives. We started out on the process of care, really sharing best practices, bringing all those things together. And as we worked together, we came up with some good statewide initiatives relative to process of care. I'll show you in some slides a little bit later how process of care rewarded us, and now that process of care is going out the window, how it is deteriorating our actual reimbursement as it relates to penalties and bonuses, but we'll go through that. We actually were number one early on in the value-based purchasing program. As we get to these future slides, it is deteriorating rapidly. Let me just say that. What we once could take great pride in is now deteriorating. What was once a reward for the state of Alabama's pool of money is 113% of the 100% we otherwise would have put in. That is deteriorating rapidly. We are expecting next year to be ranked number 40th. I don't know about you. I don't know what your football team's like, but I suspect most of us would not run around proudly proclaiming, hey, we're proud to be number 40. Okay, I don't know about you, but I think we want to be moving in the other direction and getting ourselves turned around. We are estimated to lose up to $2.1 million next year on this one program alone, on value-based purchasing. Again, I use the example of $100 for each of you, but imagine $2.1 million around the state, and this is only the one program. We're going to have a cumulative effect here a little bit later in the presentation. So these are the domain weights. You might say, well, what happened? Why has it changed? Has our care deteriorated that badly? Have we done something dramatically wrong? And I would tell you, no, it is the changing in the way in which we're being graded. As we've moved to more outcome measures and more characteristics relative to incidents and events, adverse events, for example, what we've seen is we've moved from the process of care that we were rated so well on. As you can see there, the blue, royal blue starting on your left, and you can see how it deteriorated over the next 5 years, and now it doesn't even exist in 2018 or 2019. And the domain has increased in some of the other areas. That's essentially, in my opinion, what has happened to our scores and our ranking in value-based purchasing. And again, we'll go through some specific measures a little bit later. This is the actual score, if you will, in terms of how those percentages, and you will see that 2017 we were slightly positive, and that's the one that's going to turn roughly negative 2.1 million if we continue to perform this current fiscal year that started October 1st. So again, money coming into the state is going to be diminishing. Money into your hospital is going to be diminishing if you're not careful. And I would encourage all of you to find out, what is the penalty impact for you? We have a great resource, information being provided through our hospital association. Encourage you, if you are not seeing that information, you and your chief financial officer ought to sit down and talk about it. You may not like that conversation because they may be very frustrated or angry that you're not keeping all of your dollars. But I would also ask yourself the question, what are the dollars at risk on our Blue Cross Blue Shield contract that they have with each of you? If you're not being included in those discussions, that's another area of collaboration. You need to realize exactly how much money is at risk in your organization so that y'all can make a decision. Should you create more resources? Should you create new systems? What do you need to do? How do you get engagement on that topic? Again, these are real dollars and they're real factors in your organization. The domain weights for 2018, you saw them on the slide, but this is actually the names that are attributable to them, and they're all 4 categories at 25%. So the weighting has dramatically changed since it started about 6 years ago. In 2018, I mentioned that we would see an aggregate of risk dollars. I put this up here just to try to simplify what is I've seen in a lot of other documents, but I just try to compile it into one. If you really look at the 3 programs, the value-based purchasing, readmission, and the hack penalties, essentially there are $95 million in Alabama at risk during this calendar year or fiscal year. Now, based on current performance, the loss that is projected to occur of that $95 million at risk is that we will hand back to somebody $15 million. Again, I don't know about you, but that's real dollars in most institutions that I know of. And it's money that could be well spent in a variety of other ways, including keeping your doors open, okay? Making payroll, buying supplies, buying equipment, buying something that would allow you to recruit a new physician, to bring a new service, to add volume to your organization. So these are real dollars in play, and we're going to give $15 million of them away this year, okay? That's the projection. If you go to the Hospital Compare website, it gets very confusing. I don't know about you, but I don't know how any consumer can possibly understand what's out there. I don't know how many of you can absorb everything that's out there. You're a lot smarter than I am, so you probably can do that, and that really is a good place for my hand to hit, isn't it? Sorry. I'll try not to hit it more than a couple times more. But it is very difficult to try to go out there and figure out what you're looking at, what are the years that are involved. I know all this stuff is posted, but have you ever tried to explain to people in your organization that there are certain things that are covering a certain time period and other things that are covering another time period, and when is this data going to roll off, and when is this next set of data going to come on, and what is it going to do to the overall formula of how you look in terms of value-based purchasing or your star rating? Really simple, right? Like I said, y'all are a lot smarter than I am, so I hope you have a good handle on it. But you can see that even in the star ratings, that we have different time periods for the different ratings that are on the singular website of Hospital Compare. Now, there's no specific reimbursement tied to the star rating, but what they're attempting to do is to influence the public's perception by using the star rating, which uses some of the things that have reimbursement ties, but the star ratings themselves don't actually have a direct correlation to some of the penalties and bonuses. If you go into the material within the hospital compare, you'll find the safety of care measures, and I just tried to recap these, not that I was going to read them to you today, but just so you have them in a singular location in this one slide presentation, would hopefully give you an idea of what is changing or where an emphasis is being placed in the coming years, and in some cases where measures are being moved into another domain. When we go into the safety of care, you'll see that infections continue to be an important area. Infections have historically been something we've done well on. Again, I think it's because we've had an early commitment. But our early commitment, as most of y'all recall, was in the CLABSI, CAUTI, and surgical sites. We made that same commitment in terms of the infection reporting at the state. Where we are now seem to be having more difficulty is actually outside of some of those areas. And again, I would encourage you to look at how we're doing on MRSA, how we're doing on C. diff, how we're doing on sepsis. So again, we got to keep all of our work challenged in the areas that we started in, but it's clearly growing into other areas. You'll see that again, that they're moving some into the safety domain here, some of those process measures. But for the most part, process measures have disappeared. And I personally feel like that is a mistake because I think process measures oftentimes lead to outcome measures. That could be debated by anybody, and the opinions are almost like going to Baskin Robbins. Everybody has one. Many of you may not agree with that, but I think maybe it's because I feel like we kind of cut our teeth on that in Alabama. I feel like by starting process measures, we found some consistency of what we've done, and I would like to see us take those same consistencies and move it forward on the outcome side. These are the safety of care measures that are still being included and will be included in the coming years. You can see that it includes both ICUs and regular med-surg. You'll notice that colon and abdominal hysterectomy are still there. Again, when we predicted where we might need to be taking Alabama's infection reporting legislation, we picked those two areas, and fortunately we were right on in terms of what we suspected. You'll notice that MRSA and C. diff are there, and then the Patient Safety Index Composite, PSI 90. PSI 90 continues to be a problem for many institutions in Alabama. So again, if you're doing well on that one, congratulations. If you're not, you got a lot of company. Again, we need to figure out how to steal good ideas from each other as we make this better going forward. In the value-based purchasing side, the patient outcomes, they're taking the composite from the two SSI categories. They're taking the clinical care process measures there that we described earlier. Patient experience of care. I know there's still a lot of discussion, and it's always amusing to me to hear people describe what's wrong with HCAHPS. That HCAHPS is not a fair and legitimate measure of a patient's experience. Folks, I don't know why we continue to argue that point. It's here. It's probably the best measure we have of getting a feedback relative to a patient's experience of care in our institution. Prior to this, I don't think we were doing very much, or certainly was not as in-depth as it is today. And while there may be flaws in this, and it may have some socioeconomic and demographic variables in there, the truth is talking to patients about their care and getting their answers and finding out what they think you're doing good and what they think you're doing poor, to me still has great value and benefit to your organization. Even if it wasn't in hospital compare components, I would say as an institution, I would want to know how the patients are feeling about the care in our institution. So again, I go to meetings, and I'm sure you do too, where people argue about they need to be eliminated. They don't need to be asking, so be it. But the reality is, I think it's feedback that's very helpful, and we encourage you to look at your numbers and see how you're doing. They actually have the 10 measures, but technically they make them 9 in the computations because they combine the one about quietness and the bathroom being kept clean. All right, as we look in these areas, though, there's also patient experience on the CGR and EPM, and I'm not going to try to go over that. So again, I'll hit those in a different way here. Outcome of care measures, 5 mortality and 1 complications. You see the mortality rates there. Let me just say, mortality is a problem in Alabama, okay? If you're doing good, again, congratulations. If you are not doing well in mortality, you got a lot of friends in this room. And I'm going to make an assertion, if you will, and y'all can prove me wrong. You can tell me that I'm foolish and don't know what I'm talking about, but I'm absolutely convinced mortality review in our hospitals is broken. Now, you can tell me you have a mortality review process and you can start describing it to me, but I want you to really ask yourself the following question. Do you do mortality review as a justification for that nothing went wrong, that the patient died? Or do you do mortality review to find out what could we have done differently to prevent this death? Almost every physician and every institution I know of, they review mortality on a singular case basis, and it's all about essentially nothing could have been done differently, or this is a justified death, expected complication, blah, blah, blah. How closely are you looking at those charts with a different mindset that says almost a root cause mentality? Are there things we could have done to have prevented this death, and are you taking those lessons learned and moving them forward to make changes in your organization? And are you, in fact, looking at trends and patterns for floors, for doctors, for nurses, for OR space, for whatever it is that may be a trend or pattern in your organization? I think we do a very poor job of mortality review as an industry, and I don't think Alabama is any different than that. And I would encourage you to really challenge yourself on that topic. If you really want to reduce deaths in your institution, you dig into that and you'll find some opportunities. There's no doubt in my mind. You will find opportunities to improve care by many of your services in the organization. May not have been absolutely preventable. It may have had the same outcome, but there are a lot of nuggets in that process if you will apply it. Readmission measures. We kind of got the good and the bad. We have some that are better than others, but these are the ones that are there. Again, I would tell you that we've really got to look at the total hip and total knee. I'll show you the data here in just a little while. Efficiency measure, I'm not going to spend a lot of time on that one. It's the Medicare spending per beneficiary. Again, it's the 3 days prior and the 30 days afterwards. You would think with Alabama having some of the lowest Medicare reimbursement rates in the country that we would be just looking wonderful on that. But you know what? We really like to use post-acute care. We like to use hospice and home care and DME and many other services in addition to the hospital care, and therefore our data does not necessarily look that good when compared to other states. So let's start looking at some of the individual data points. I want to thank Bart Pravill with AQUAF, who is always so kind to get the information for us. And look how we rank in this particular case. We are number 47 on the rate of complications for hip and knee. As we go through the slides, we'd like to think, I think, that we do great heart care and great orthopedic care in Alabama. And I'm not standing here trying to be critical, but the data is what the data is. And I would tell you that we can't pat ourselves on the back for a lot of our cardiac and a lot of our hip and knee activities in the state when you look at these data. Again, we are 47th in the country in this particular case. This is one of the HCAP scores. We're ranked number 32 on keeping the bathroom clean, or at least the patient's perception of that. We are below the national standard. We're number 13 on nurses always communicated well. And let me challenge you again to take this data, take it back with you, look at your individual institution. And if you see Alabama ranked number 13 and you and your hospital are below the national average, what is it you're doing different than the rest of the people in the state of Alabama? Or vice versa. Maybe Alabama's rated low and you're at the top on performance. We need to steal your good ideas about what's working for you. But take this and really challenge yourself in terms of how your data looks. We look very good here about doctors always communicated well. I wish we could transpose that into the nursing side because the nursing scores are typically not as strong as the physician scores in that area. Always received help as soon as they wanted it. Again, you see we're ranked number 27. Patients reported that their pain was always well controlled, and we had a lengthy discussion this morning about the impact this question may be having with opioid usage, and that'll be a topic you'll hear more about today in terms of what is going on in this area. Again, I would say that we obviously are scoring well on this, but it seems to be institution specific. There are some institutions doing really well on this one, and some institutions doing very poorly on this. So again, I would encourage you to look at your own. This is how we score on medicines. Again, the same correlation, many at both extremes of this in the state. Some that are doing really well, some that are doing really poorly. I think this has a huge impact on the discharge planning and the ability to manage length of stay in our institutions, as well as probably the satisfaction of patients regarding the care that they're getting. Ranked number 36, and they were giving information about what to do during their recovery at home. To me, that's a pretty big indictment. You know, it's interesting to me, and I've always kind of advocated, it's amazing to me that we can have a patient in ICU, we can have a patient in med-surg, and we need them in here for a continuity of care. And then all of a sudden, when the car pulls up at the front door, and we send them home with no information to manage themselves to a degree that they're comfortable with based on this answer. So I think we have a huge opportunity to do a better job of serving our communities with this. All right. Understood their care when they left the hospital. Again, I think this correlates exactly to the point we just made, and we ranked number 40th. You know, I don't know about you, but it seems like in the South we'd be a lot better than that with all of our friends and neighbors and small communities that we have to work with. So again, I would encourage you to look at that one. Patients who gave the hospital a rating of 9 or 10 on overall score, we ranked 24th. In terms of patients who reported the area room being quiet at night, we ranked 3rd. That's because all our staff was sleeping, so they weren't creating. No, I'm sorry, just kidding. Whatever we're doing there well, we need to continue to do. Patients who would definitely recommend the hospital, ranked number 27. Again, I personally would find that disappointing, and if my individual institution was not scoring better on this, it's hard for me to imagine this person giving a positive recommendation to their friends at church or at school or PTA or in the neighborhood. To me, this is the highest correlating factor in terms of whether you have a brand or a reputation or a future as an institution. If you're not scoring well on this category, I think you have problems in your organization that are likely to come back to haunt you at some point in the future. All right, surgical site infections for colons, we rank extremely high, number 3. Not quite so high on abdominal hysterectomies, we rank 30th. MRSA, 42nd. Number 3 on C. diff. AMI mortality, watch these carefully, 48th. Death rate for cabbage, 46. COPD, 17th, a little better. Heart failure, 24th, a little better. Pneumonia, 45th. Strokes, 31st. Medicare spending per beneficiary, kind of in the middle of the pack at 27, similar to the comment I made earlier. Blood clot after surgery, 26. Bloodstream infection after surgery, we actually ranked number 1 on sepsis, post-surgical, but I want to emphasize it's post-surgical. Wound that splits open, I never liked that wording. It sounds pretty gross, but that's the wording that they put on here. Number 15. Accidental cuts and tears, 23rd. Pressure ulcers, 22. Again, here's one, deaths. If you see a common theme by the message I'm trying to give to you, deaths are killing us. Sorry for the play on words. Mortality and deaths need your attention, okay? Collapsed lung, 32nd. Infection, large venous catheters. Serious complications, 23rd. This is the HACS reduction program. I'm going to have just a few slides here. You'll see the HACS we seem to be doing very well on. Again, I think that's because of the work that we put in place early on, including our Blue Cross contracts, which had some information there. Readmissions, this slide is not as current as some of the other data, but you'll notice on the far right column that we have lots of work to do in the readmissions arena also, some worse than others. And again, I'll let you review that on your own. But again, I think the mortality and readmissions are the area that if you want to look at where we're going to have penalties in the future, those are probably the areas that need our attention. I tried to put this together just as a compilation of all the areas that we talked about today, or that in review of the data in preparation. These are some of the areas where we rank. I honestly would just take this list, go to your institution, and see how you look. If you want to boil it down to the hot spots, these are the hot spots for the state. They may not be the hot spots for you, but you need to find out what the hot spots for your organization are, because it does impact the dollars, but more importantly, it impacts the clinical outcomes. Names here, 3 people I hope you know. I hope you have met them. I hope you will reach out to them. They are tremendous resources for each of our institutions in the state. They do great work on our behalf, whether it's in the HEN program or whether it's continuing to coordinate our quality task force and the quality forums like we're having today. They can help get you information if you need it. I know that they often call on you and try to learn from your experiences and identify those best practices and share them around in statewide forums. Again, we want to learn to help each other. It's our goal that everybody is a top-performing hospital in this area of quality. It's not an area that anybody needs to be second or third. Everybody needs to be at the top. So I'm kind of getting to the end here now, back to, do you really have a team? Do you have a collaborative process in your organization where the team comes together and talks about these important topics? Does the team come together in a concurrent way, or is it something you do at the end of the month? You do it once a quarter. If you're doing it once a month and once a quarter, you're too late. You need to be doing it while the patient's still in the house. You need to be doing it while the patient's still able to be addressed so that you can avoid the complications, avoid the risk. And if you need to do physician queries or you need to do some intervention, it needs to be about the concurrent review of care. It includes that you've got to have the nursing leadership and the nursing staff engaged in that process. You've got to use HIM, case management, risk, IP, wound care. Everybody's got to be at the table playing on this topic. It is not a retrospective review process. It is about concurrency, and it's about saying that that's what we stand for as an institution. So in closing, let me just ask you the following question. If I were to ask your peers as your career ends one day, this is a question I posed to myself, and I've posed it to lots of other groups in the past. If I pose that question to the people that you've worked with, what would they say you stood for? And what would they say you did as a contribution to health care? Would they say that you made a difference in your hospital? Would they say that you changed and improved the delivery of care for your patients and lives were saved? Where they said that you were one who would stand up for doing it right and making sure that we intervened and made sure that the patients were treated with kindness and respect, and that the patient's outcome, that a family could leave that night at 10 o'clock knowing that their care of their loved one is in the hands of people who are going to take great care of them, and they could sleep peacefully, that their loved one was not going to be subjected to harm or risk or oversight because you had good processes in place, you had good training for your staff. So I hope you'll just think about that question. What do you want to be known for? What do you stand for? And are you making a difference in your institution? Because this is the group that can do that. This is the group that can drive that performance and improvement. You've done it in the past. I'm confident you'll do it again. And it is a pleasure to get the chance to work and interact with all of you. And I look forward to continuing to see great practices coming from your hospitals that we can share with others. So this is our challenge. You see the spots we're good. You see the spots we have trouble. Let's make a difference in our state, and I applaud your efforts. So thank y'all very much. I'd be happy to answer any questions if you have any. If we have time. Margaret, are we on time for a couple of questions? Anybody have any questions? It's normally a shy group, I know. Okay. If you have a tough question, I'm just going to pass it off to somebody else, okay? All right. No questions? All right. Well, thank y'all very much. I appreciate your attention.